Hello everyone, welcome to Samson's Medlin Academy. So myself, I'm Swati Sandhya Samban. So today we are going to discuss DHA exam, recent questions and answers. So let's begin. Yeah. So the first question is a 45-year-old man is admitted with severe gram-negative infection and started on tobramycin IV once daily. So it is given as a high-dose extended interval regimen. Okay. So the resident asked why this dosing strategy is preferred instead of multiple smaller doses throughout the day. So the question is, what is the rationale for using a high-dose extended interval tobramycin regimen? So option A is it reduces the risk of ototoxicity by lowering peak concentrations. So option B is it provides more stable drug levels throughout the day. Option C is it reduces the risk of nephrotoxicity due to less renal tubular exposure. And option D is that it minimizes the need for therapeutic drug monitoring. So let's understand the question. Here we have a 45-year-old man. So he is admitted with severe gram-negative infection. Okay. And he started on tobramycin IV once daily as high-dose extended interval regimen. So now the resident doctor is asking, why should you give this tobramycin as a high-dose extended interval regimen? What is this extended interval regimen? You give a high dose of a drug and then there is an extended interval, that is there is an interval like 24 hours. So you give a high dose, you give the next high dose after 24 hours. Okay, so that is this high dose extended interval. So the resident is asking why you are giving the drug like this. Why can't you give it as multiple small doses throughout the day? Okay, so that is his doubt. So what is the right answer in this? Immediately you see tobramycin, you see that it is an aminoglycoside. Don't go and jump to this autotoxicity. Okay. So the right answer to this question is actually option C. It reduces the risk of nephrotoxicity due to less renal tubular exposure. So that is the right answer. So we'll try to understand how this becomes the right answer. We'll also have a general understanding how to approach such questions. Okay. So the answer is it reduces the risk of nephrotoxicity due to less renal tubular exposure. So this high dose extended interval dosing, that is once daily of this aminoglycosides like this tobramycins, it works better and is safer because of concentration dependent killing. So in this antibiotics, we have two divisions. That is you have the concentration dependent killing and you have the time dependent killing. So these patterns determine how the drug should be dosed to maximize the bacterial killing and to minimize its toxicity. So that is what we want, right? We want to maximize the killing of bacteria and we want to minimize the toxicity. We don't want toxicity to happen also. So the drugs are generally classified as concentration and time. There are some drugs that shows mixed, that is both this concentration and time dependent, both will be exhibited. But generally it's of two types. Let's have a brief understanding. Okay. So in dose dependent killing, you can see from the graph, you give a drug to the patient and what will happen? The concentration of the drug in the blood, it reaches the C max, that is what is that orange line? That is the MIC. That is a minimum inhibitory concentration. Minimum, you need that much amount of drug for the killing of bacteria to happen. That is minimum inhibitory concentration. Okay, we know that. So then it will go above the minimum inhibitory concentration, reaches the C max, then it falls down nearly to zero. So the examples there in concentration dependent killing is the aminoglycoside is a classic example. Okay. So here the efficacy depends on the peak concentration. That is the C max is what we want to achieve here. So reach relative to the MIC, C max relative to MIC. So higher peaks result in more effective bacterial killing. The goal is to achieve a high peak to MIC ratio. Examples are the aminoglycosides, the gentamicin, the amikacin, also drugs such as fluoroquinolones. So they are the examples. And what is the dosing strategy here? So you will give a high dose less frequent, that is often once daily, to achieve high peak, allowing concentrations to fall low between the doses. So why do you want it to fall low? Because it is giving the tissue the time to recover from any possible toxicity. So what is a challenge when you're giving a higher dose? There is high chance of toxicity, right? So for the toxicities not to happen, you give the tissues time so that they can recover from any possible toxicity. Now, look at the time dependent killing. Let's have an understanding of the time dependent killing. You give a drug to the patient. Imagine a meropenem or piptas or something like that. So you have the TID. You give it thrice a day. Okay. So you give the drug, the level in the blood, the concentration increases. So it will increase, it will go above the MIC, and then what? It will slowly start to fall, right? So when slowly starts to fall, what do? You give the next dosing. So what will it go? It will again rise. Okay. Again, it will start to fall. What will you do? You will give the next dose. Again, it will rise. So likewise, you're trying to maintain the drug above the MIC for a long duration of time. So this longer duration of time it stays above the MIC is where the killing happens. So in time dependent killing, the efficacy is it depends on the amount of time the drug concentration stays above the minimum inhibitory concentration of the pathogen. Okay, the goal here is to maintain drug levels above the MIC for as much of the dosing interval as possible. Classic examples are the beta-lactams, the penicillins, the cephalosporins, the carbapenems. Okay, dosing strategy is you need to give it frequently and smaller doses or continuous infusions in like ICU patients. You can give the meropenems as continuous infusions. Okay, so maximize the time more than the MIC, that is time about MIC. That's the goal here. You need to have an understanding of these concepts when you're approaching these questions. You can just understand by looking into the frequency. You see a frequency TID or you see a frequency OD. So once you see OD, you need to understand, okay, that might be a concentration dependent killing because it's given once daily. And you see a GID, you need to have an understanding, okay, this might be a time dependent killing. You're giving it 3 times, or maybe in some cases, it's given 4 times a day or as continuous infusions. Okay. Okay, there is, okay, we understood that aminoglycosides is concentration dependent killing. Okay, done. No, now the next point is aminoglycosides also exhibit a post antibiotic effect. You look at this graph, you can see it goes above the MIC, it reaches a Cmax, then it falls, right? So it goes below the MIC. So what is it? It is going below the MIC. So these drugs, they continue to suppress the bacterial growth even after the drug concentration has fallen below the MIC. Even during that time, it does the bacterial killing. So that is the advantage there. So this allows for longer dosing intervals can be done with these aminoglycosides. Thinking about safety, the two things that comes to our mind is the ototoxicity and the nephrotoxicity. So here in nephrotoxicity, aminoglycosides can cause kidney toxicity. It actually accumulates in the renal proximal tubule cells, which is exposure dependent, and with once daily dosing, the drug level falls to nearly zero before the next dose. So this allows the kidney cells to the time, it gives the kidney cells the time to recover and reducing prolonged drug exposure in renal tissues. And in safety, definitely there are risks of ototoxicity, but in this regimen, it does not actually lower the peak concentration. So actually the peaks are higher. So the reduction is in ototoxicity is not actually the primary benefit here. Also, one more point is like when you give it correct higher doses are given, no, it lowers the risk of any resistance, adaptive resistance that can happen because we are treating bacteria and bacteria are prone to having resistance. Okay. You can go refer the Goodman Gilman, the Dipero, the KD Tripathi. You can go through these textbooks. Okay, so these are some of the references. Moving on with the next question. So here you have a 60-year-old man. So he is admitted with severe pancreatitis, is unable to tolerate oral or enteral feeding, and is started on total parenteral nutrition, that is the TPN. So as part of routine monitoring, the healthcare teams wants to check the appropriate laboratory parameter at baseline and then weekly while the patient continues the TPN. So, which laboratory test should be monitored in this manner? Understand the question. The patient is not taking anything orally, and the doctor has started total parenteral nutrition for the patient. So, when a patient is on parenteral nutrition, which laboratory test should you do initially and on weekly basis? The question is clear. I hope you have got four options. Option A is serum creatinine. Option B, liver transaminases. Option C is the serum triglycerides, and option D is complete blood count. What do you think the right option to this question is? The right option is actually option C, that is a serum triglycerides. Why? Because this total parenteral nutrition, it is a method of feeding that bypasses the gastrointestinal tract. Just understand that, okay, delivering nutrients directly to the bloodstream. So this total parenteral nutrition, it contains lipid emulsions, and lipid emulsions, which are fats provided intravenously as source of calorie and essential fatty acids. Now you know, right, why it is serum triglycerides. So serum triglycerides are the primary biomarkers for monitoring fat metabolism and detecting lipid intolerance or complications related to TPN. If triglyceride levels rises excessively, there is an increased risk of complications, including pancreatitis. And here already the patient is having pancreatitis in the question, and it can also cause problems like fat overload syndrome or other metabolic disturbances. So baseline measurements before starting TPN, it is important to assess the triglyceride. So before starting TPN, the patient should do you should do a blood test for the patient, that is the serum triglyceride should be monitored. Okay, it is important to assess the serum triglycerides to ensure that there is no pre-existing lipid metabolism disorder is not there in the patient, and also weekly monitoring. So continued weekly checks allowing for early detection of hypertriglyceridemia and gauge adjustments in the lipid component of the TPN if necessary. So this is the answer to the question. So other option like serum creatinine is for the kidney function. It's not part of the routine for the TPN monitoring. It's not a routine practice. Liver transaminases can be checked as TPN may cause liver dysfunction over time, but triglycerides are specific parameter for for this in this scenario. Complete blood count definitely useful for overall health understanding. The health of the patient, but specifically for TPN lipid monitoring, it is not the one. Okay. References, you can refer to the parenteral nutrition handbook and also guidelines for use of parenteral and enteral nutrition in adult patients. Okay, you can refer to this. I hope this question is clear. Next is a 28-year-old woman of Southeast Asian ancestry is diagnosed with new onset focal epilepsy. So genetic testing was done as part of her evaluation, and it reveals that she has HLA-B 1502 positive. So the neurologist wants to start an anti-seizure therapy. So which anti-epileptic drug can be used safely? So that is a question. Which anti-epileptic medication would be safe to use in this patient? You need to learn the genetic testings and the things related to this genetics. You can expect questions from these areas. So be aware of that, have an understanding what will happen when specific genes are present in people, what can it do when those people with this genetic mutation receives a drug, what how their body reacts. Have an understanding of these types of questions. You can have questions from these areas. So options in this case, which anti-epileptic medication? Option A is the carbamazepine, option B phenytoin, option D C is lamotrigine, and option D is levetiracetam. What is the right answer to this question? The right answer to this question is levetiracetam. Let's see. Let's understand each of these questions. So HLA-B 1502 is actually a small piece of genetic information that people inherit from their parents. They may or may not inherit. Okay. It is found more commonly in people with Southeast Asia, such as Chinese, Thai, the Filipino populations. They are they're mostly having this type of genetic mutation. So this gene is a part of the body's immune system. So in most, we'll come to that later. Okay, in most of the cases, it helps the body respond to infections. Some epilepsy drugs, such as if it is a carbamazepine, can react badly with HLA-B 1502. If a person is having HLA-B 1502 and that patient is going to get a carbamazepine, it can react very badly. It can be even life-threatening. Okay, in people with these gene mutations, these drugs can cause immune system to attack the skin and mucous membranes. They can lead to severe conditions like the Steven-Johnson syndrome and toxic epidermal necrosis (TN), where the skin blisters and peels off. So this can be actually life-threatening. So carbamazepine, from the options, we now know that carbamazepine should not be given to patients with this genetic mutation, can be very dangerous. So HLA-B1502 gene is actually a part of a group of genes called the human leukocyte antigen. So this HLA is the human leukocyte antigen system. So they are part of this. So what is the key job of this? So what they do is they help the immune system recognize what belongs to the body and what does not. Okay, so if there is a foreign, some germs or bacteria or fungus or anything is trying to get into the body, it helps the body recognize, okay, you have got a foreign object from outside, it is trying to invade your body. So when a person with HLA-B 1502 gene takes drugs such as carbamazepine, now the problem happens. So this drug can, what happened is this drug carbamazepine will go and bind with the HLA molecule. So this new combination, this drug and the HLA molecule combination, this will act as a false alarm, okay, for the immune system. So the immune system thinks this drug HLA combination is dangerous, and the T cells, that is our immune cells, they'll go and attack the body's own skin cells and mucous membrane, mistaking them for a threat. So this will cause painful blisters, as I said before. But this is like reactions are very rare but very dangerous. Um, this is why genetic testing is very, very important. So for drugs like phenytoin and lamotrigine, they also carry this risk, but not that high as carbamazepine. But levetiracetam does not cause this reaction and is safe to use in these patients. So that is why it's a best choice for someone with HLA-B 1502. Okay. Now doctors check for HLA-B 1502 before starting certain epilepsy medications. If the gene is present, they pick a medication like levetiracetam that does not interact dangerously with this gene. So this helps keep the patient safe from any skin reactions. You can refer to these, okay? The guidelines for carbamazepine, uh, epilepsy, and anti-seizure therapy recommendations. Next, you have a calculation. So before moving and starting going with this question, I want all of you to know, many will be knowing that for the DHA exams, for the calculations, you will not be provided with pencil, pen, paper, nothing. It will not be there. You will have, that DHA exam is an computer-based exam. You will have calculators on screen. So make sure that once you understand the equations, you write and study and everything, you need to practice these questions with the help of on-screen calculators. Only then you will get the proper time and speed, and you can manage if you want to manage these questions on the exam, then you need to do it prior. You need to practice it with on-screen calculators. Only then you will get that prep to do it on the exam day. So now let's see the question. Okay, just keep that in mind. And a man weighs 78 kg is to be administered 1 gram vancomycin intravenously every 12 hours for 7 days. So the half-life of vancomycin, it's approximately 8 hours, and the volume of distribution is approximately 1 liter per kg. What is the expected average steady-state plasma concentration in mg per liter for of vancomycin? That is a question. Okay, so whenever you get a question, you try to have an understanding about the question in your mind. We have got four options. That is option A 5, option B 7, option C 13, option D 90. This DHA people have a What they do is, which are ways you can go wrong, and the wrong way of calculating and the wrong answer, no, you will have that wrong answer as an option. So be very careful while doing the question and selecting the answers. So this question, I think this question is from the null file. I've got this question for my exams personally. This is an important question, I would say. So what all are the given data from this question? This is a pretty simple question, but the only problem with this question is the steps are a bit lengthier, and yeah, uh, the lengthiness is the problem, because you need know the equations, you can do the question, just you need to practice so that this length and the steps of the question doesn't becomes a problem during exam. Patient weight is 78 kg. The dose is 1 gram, 1 gram 1000 mg. Every 12 hours is like 2000 mg per day. Just have this, those understandings. Dosing interval, that is a tau is 12 hours. The T half is 8 hours. Volume of distribution, it is said 1 liter per kg. We know the weight is 78 kg. So it is 78 liters. Okay, done. That is all we have got from the question. Now, what is the equation for steady state? So the steady state, the equation is dose per dosing interval divided by clearance into this tau. What is this tau? Is the dosing interval. So this is the equation. But what is the problem? We don't know the clearance. The clearance is not directly given in the question. But we know for clearance, the equation is K into BD. So we have two equations now. Okay. But again, for this, we need to get what is K. So for K, to finding K, there is another equation that we know that has K. What is this equation? That is for the T half. So in T half is 0.693 divided by K. Okay, so now this is like simple cross multiplication. So when you substitute in the T half equation, from that you will get the K. So now cross multiplying, K is equal to 0.693 divided by T half. When you substitute that, you will get one answer. Keep that answer in your mind, because you can't note it down anywhere. Keep that answer in your mind. Now, in the clearance equation, you're going to substitute that answer. Okay, 0.0866 will be substituted into volume distribution. You already calculated and kept. That was 78. Into 78, you will get the clearance. Now, keep that clearance in your mind. And what should you do? You should now go and substitute that in your steady state calculation. Okay, that is dosing per dosing interval is dose per dosing interval is 1000 divided by, we have got clearance, that is 6.75 into the dosing interval is 12. So 1000 divided by 81, you will get 12.35. It is approximately 13 mg per liter. It is option C. Please do calculate this, practice it with pen and paper, and then practice it without pen and paper. Please do that. Practice it with on-screen calculators. Make sure you are getting the answers. Yeah, do that. Yeah, refer to Dipiro and applying clinical pharmacokinetics. You can see these equations. You can practice more questions like this. So the next question is, we've got a 50-year-old man with type 2 diabetes, has been trying to manage his blood sugars with diet and exercise. He decides to include certain kitchen herbs in his meals to help lower his blood sugars naturally. So, which of the following herbs is known to reduce the hyperglycemia? That is a question. Simple question, right? So what will be the answer? Option A, ginger. Option B, fenugreek. Option C is turmeric. Option D is basil. So which of these have you heard of and having a property to reduce the blood sugar levels naturally? So it is option B, it is fenugreek. You can expect such questions from cognosy, okay? Option B is fenugreek. So fenugreek seed contains soluble fibers and bioactive compounds. You just have a brief understanding, need not understand, have a deeper understanding on that. Just understand that fenugreek reduces the blood sugar level. So it slows the carbohydrate absorption, stimulates insulin secretion, improves insulin sensitivity, and lowers blood sugar. So other herbs, they are having other general health benefits, but less effective with blood sugar control. The mechanism is actually the sol. It has got soluble fiber contents, so this it has high amount of soluble fiber, which slows the gastric emptying and glucose absorption from the intestine. So it has got two amino four this hydroxybutyric acid, that is the compound, something similar to GABA like compound. So this may help stimulate the insulin secretion from the pancreatic beta cells. This can be the reason how it lowers the sugars. There are some clinical evidence studies in some clinical trials that people have done, and which have shown that fenugreek supplements, the 5 to 25 grams per day, has significantly lowered the fasting blood glucose and the HbA1c in type 2 diabetes patients. And also, like, fenugreek has a mild but consistent glucose lowering effect, especially when you use alongside with lifestyle modifications. It is shown to have some effects. We can go refer these, you can, for your references and more understanding on this. Now, question number 6. You see a big, long paragraph. Don't get worried seeing such paragraphs. You can expect questions from social and behavioral. Questions can be this long, but trust me, they're really simple. You need to don't get worried seeing this question. You take time, read the question, understand, look into the options, try to find the go through all the options, think which option will suit the best, pick that option. Okay, it is not difficult, the social and behavioral, but it can be lengthy. Okay. So, a 45-year-old woman comes to the outpatient pharmacy of a tertiary care hospital, visibly upset and frustrated. She has a prescription for a newly prescribed antihypertensive medication. But when she presents it at the counter, the pharmacy computer flags the prescription due to insurance restriction. So the patient immediately begins raising her voice, accusing the pharmacist of delaying her treatment and questioning why the pharmacy cannot override the insurance system. So she claims that the delay is affecting her health and repeatedly interrupts the pharmacist while trying to explain her situation. So the pharmacist now feels stressed, and other patients are waiting, and the situation is beginning to draw attention from nearby staff. So the security is present nearby, and a few staff members are they're also watching. So the pharmacist knows that the hospital has very strict policy regarding the insurance verification, and any deviation could have legal consequences. So, in this situation, which of the following action would have been the most appropriate for the pharmacist to take at the very beginning of the encounter? Option A, ask the patient to calm down. Option B, walk away and call the pharmacy manager. Option C, interrupt the patient and defend themselves. Option D, listen quietly and explain the policy after the patient finishes. Read the question, read the option, pick the right answer. What do you think the right answer to this question is? Option D, listen quietly, explain the policy after the patient finishes. So, listening quietly and allowing the patient to express concerns fully actually helps de escalate the tension and shows empathy. After the patient finishes, the pharmacist can calmly explain the policy, provide guidance, and discuss next steps. Interrupting and shouting and walking away can actually worsen this conflict and harm the patient pharmacist relationship. Okay, refer to this. Question number 7 is, again, you have got a question which looks very complex. Let's see what is there in the question. A patient working for a private company has comprehensive health insurance that covers prescription drugs through a defined formulary. Understand? The patient has health insurance, but the health insurance that covers prescription drugs, only the drugs in the defined formulary. Only for those drugs the insurance will cover, okay? After visiting his cardiologist, he is prescribed, excuse me, XYZ 5 to 50 mg. There might be a big drug that will be returned, the 55 to 50 mg tablets and all will be written the question. Combination of hydrochlorothiazide and amiloride once daily. So, which is not included in the insurance formula? It is not inside the insurance formulary. Now, that is the trouble here. It is not inside the health insurance formulary. The pharmacist dispenses the prescribed combination as requested, and the patient and asks the patient to pay SAR 50. SAR is this Saudi Arabia Riyal. Okay, 50 for 2 tablet packs. Which of the following actions by the pharmacist was inappropriate according to Saudi regulations for private sector delivery? So now in this question, we have got four options. So one is did not do anything wrong. Option A. Option B should not ask the patient to pay for the product because it is covered in health insurance. Why did the person ask to pay this much? Next is did not call the physician and ask him to write the formulary complaint prescription. Okay, that is option C. And option D is should not automatically switch the product to another drug without physician approval. So they have dispense a drug and they should not have automatically switched the product to another drug without the physician's approval. They cannot do it like that. Okay. So what do you think the right answer to this question is? So the right answer is here you can get a bit confused because the options uh, some options might be a bit confusing, but the right answer to this question is he should have called the physician and asked him to write a formulary compliant prescription. Okay. So when a prescription prescribed medication is not included inside an insurance formulary, the pharmacist is expected. What they expect is for us to contact the physician and to discuss a formulary approved alternate. So dispensing a non-formulary combination without consulting the physician may actually violate the insurance and the healthcare regulations in the private sector. So while asking the patient to pay or switching the drug without approval are separate concerns. They are also big concerns. The main regulatory breach here is that he did not coordinate with the prescribing physician. So that is what is expected from the pharmacist. Because when you see such a prescription, you need to make sure that you need to call the physician and tell them that this is not there in the formulary, and I would like you to write. I would expect. I mean, just ask the physician to write a drug that is there in the formulary. Okay, can refer to these. You can refer to the Ministry of Health, the Saudi Food and Drug Authority guidelines for this. Next is again you have a longer question. Question number 8. In a busy outpatient pharmacy of a tertiary care hospital, the pharmacist is checking and dispensing prescriptions for several patients waiting in a long queue. So an elderly patient who has been waiting for over 15 minutes, okay, approaches the counter and says in a slightly irritated tone, I've been waiting for a long time. Can you please hurry up? So the patient is asking, okay. So the pharmacist is aware that the prescription needs to go through a careful process of verification, checking of the drug interaction, and proper labeling before being handled to the patients. So, but also wants to maintain good communication and patient satisfaction. Which of the following represents the most assertive and professional response by the pharmacist? So that is the question. Don't miss the word assertive and professional response here, okay? Keep that in mind. Option A is you are right, it is taking longer than usual. Option B is I'm sorry, but you need to wait your turn. Option C is you want to ensure that you get the correct medication and those, so please be patient. Option D is everyone else has to wait too, so you have to be patient. What do you think the right options? Here also, the social and behavioral questions at times can be a bit tricky. Don't be like worried about it. You read the question, understand, look for words such as assertive, professional response. That is what they're asking for. Okay, so the assertive, professional responses, you need to acknowledge the situation. You need to tell them, you are right, it is taking longer than usual. You need to acknowledge the situation to the patient. An assertive professional response actually acknowledge the patient's concern without being defensive or dismissive. We'll not say that in this, we'll just acknowledge them, saying that this is what is happening, it is taking longer than usual, while maintaining a professional and polite tone, a professional, polite and professional tone. Option A actually validates the patient's frustration, shows empathy, and reassures them. Okay, while option B, C, D either comes across dismissive or instructional or rude, which could escalate tension and reduce patient satisfaction. So assertive communication actually helps build trust and professionalism even in busy and stressful environment. We need to just acknowledge that situation. Be professional in the dialogues you speak. Okay. Refer to these. You can refer to these for this. Okay. Next is a question from statistics. Let's see. A clinical study reports that the average fasting blood glucose level of participant is 100 mg per dl. What is the standard deviation of with a standard deviation of 10 mg per dl? Which of the following is the best interpretation of this findings? So we have the value as 100 mg per dl with a standard deviation of 10. Standard deviation is 10. Option A is most of the participants had fasting blood glucose levels between 90 and 110 mg per dl. Option B, most of the participants has fasting blood glucose level within 10% of the mean. Option C is most of the participants had fasting blood glucose levels within 20 mg per dl of the mean. Option D is most of the participants had fasting blood glucose levels within 50 mg per dl of the mean. What is the right answer? This is a simple question. The right answer is most of the participants had fasting blood glucose levels between 90 and 110 mg per dl. The standard deviation, it measures how spread out the data are around the mean. Okay, so here 100 plus or minus 10 mg gives a ranges. It can have a 10 percentage, 10 mg per dl deviation. That is, it can go to 90 mg per dl or it can go to 110 mg per dl. So that is a correct interpretation. Option B is incorrect because standard deviation is not expressed. It is not expressed in percentage of the mean. C and D gives ranges that are much wider than the one standard deviation and do not represent the typical distribution. Okay, so when you get a question from statistics, understand the mean, median, mode, central tendency, the standard deviation. Yeah, just have an understanding of this so that you can expect questions from these areas. You can refer to books on biostatistics and medical statistics. Okay. So this is our final question. An 80-year-old patient with reduced renal function is prescribed a renally excreted antibiotic. So reduced renal function, given a renally excreted antibiotic, laboratory results show a significant reduction in creatinine clearance is also reduced. Which pharmacokinetic parameter is most directly affected by this reduction, especially in elderly patients? Option A, bioavailability. Option B, volume of distribution. Option C is half-life. And option D is protein binding. What is the right answer to this question? Very simple, right? It is option C, half-life. As we know, creatinine clearance is a key measure of renal function. Drugs that are primarily eliminated by the kidneys will have reduced clearance in patients with impaired renal function. So this leads to prolonged half-life as the drug stays in the body longer. So volume of distribution, bioavailability, and protein binding may be influenced by age or disease, but the half-life is the most directly affected by decreased renal clearance. Half-life, most directly affected. So what is half-life? It is basically the time required for the plasma drug concentration to reduce by half. So if it needs to reduce by half and it needs to go out, there should be clearance. If clearance is not there, it cannot be done, no? As we were discussing in the previous calculation question, T half is 0.693 into VD divided by clearance. Okay. And as the clearance decreases, the half-life actually increases. Okay. As the clearance decreases, the half-life increases. In a patient with low creatinine clearance, the drug clearance drops, kidneys remove less drug per hour, the drug stays in the body much longer, risk of the drug accumulation and toxicity rises unless the dose or dosing interval is adjusted accordingly. So you can refer to Goodman-Gilman and the FDA guidelines for pharmacokinetic in patients with impaired renal function. I hope it is clear for everyone. Thank you everyone for listening to the session. Yeah, thank you.